Welcome to AETCM, the Emergency Medicine channel. Today we will be discussing about jaw dislocation. So we have a young male who presented to our ER with complaints of inability to close the mouth after yawning. So it is a case of anterior dislocation of the mandible. So basically when we are coming to the dislocation of mandibles, there are actually dislocation can happen at any ways. Either it can be anterior or posterior or lateral or superior. So anterior dislocation is the most common, and it usually occurs when the joint capsule, that area is very shallow, or if there is some this patient is having some connective tissue disorders and this joint is very lax, or if in case of any seizures or in case of electric shocks and all. And sometimes after that what will happen is this patient's mandible will dislocate anteriorly, and patient will not be able to relocate that because of the masseter spasm. Okay, so this is the most common, that is the anterior dislocation. It usually happens when patient yawns, or patient is opening the mouth and laughing, patient is opening the mouth wide open for taking food, or it can be iatrogenic also. If the patient is sitting in front of the doctor and doctor is examining the oral cavity, that time if patient is opening the mouth, that can happen. Or during any surgeries like tonsillectomy, dental procedures, or even for general anesthesia, while we are trying to intubate a patient also, this anterior dislocation can happen. Coming to lateral dislocation usually occurs when the after a trauma. So it will be dislocated laterally, and there can be associated fracture of the mandible, either the neck of the mandible or the condyle of the mandible. There can be a fracture also. And if it is superior dislocation means the mandible will be going upwards. So the temporal part of the brain can get injured, and there can be brain contusions and all. And if it is a dislocation posteriorly, just behind the mandible we have the external auditory canal. So the external auditory canal can get involved, and patient can have deafness. So depending on what type of dislocation it is. So if it is anterior dislocation, it is okay because it is the most common one and it is somewhat safer one. So we don't want to do any imaging for that as such. But if it is something related to trauma, and if it is looking very abnormal, if the patient is having symptoms of facial nerve palsy or deafness, or some features of altered sensorium, low GCS and all, we will have to do imaging like that. So usually the panoramic view is advised, but if we are anticipating some extra injuries, we will have to do a CT brain and all. So this is the classification of the dislocation. So as I told, anterior dislocation is most common, and it usually occurs whenever the patient has to open the mouth widely. Okay, so if such a patient presents to our ER, patient will be presenting, telling us that he will not be able to tell the words correctly. Patient will be showing actions that he is not able to close the mouth completely. Patient might not be able to swallow the saliva, or patient may not be able to swallow the food and all, and patient will be having excessive salivation also, and patient will be having severe pain. So in this cases we will have to as we go according to the primary survey, we will have to deal with the airway, breathing, circulation, disability, and we will have to give analgesics necessary, whatever analgesics is necessary. We cannot give any oral medicines for this patient. So in the disability part, when we are checking, we will be seeing if it is an anterior dislocation. We will be talking about the anterior dislocation here. We will be seeing that the mandible is prominent and it is anterior, and patient will be having tenderness in front of the tragus. Tenderness in front of the tragus. That will be the clinical features which will be seen, and depending on the history, and if you are not suspecting any trauma or any fractures, we can directly correct that without even taking an X-ray. So we will be discussing about the different type of maneuvers that can be performed to relocate the displaced mandible. So before that, we will have to give analgesics to patient, IV analgesics, because we cannot give any oral analgesics, and we will have to, depending on the patient, we will have to plan on procedural sedation also. So we have to take the consent for procedural sedation. We will have to we have to place 2 large bore IV cannulas, cardiac monitors should be connected, and we can give either a procedural sedation with midazolam and fentanyl, or we can give a local anesthetic. That means 2% lidocaine, 2% can be given in front of the tragus in that temporomandibular joint area can be given, and then we can correct that. Okay, so once that is given, then we will, what all things to be arranged? We need gloves for the exam for the doctor. Then we need a packet of gauze because we will be relocating with the gauze. Then we want suction, Magel's forceps, and a bite block. Sometimes the doctor, we will be inserting the hand into the patient's mouth. Sometimes we might get a bite. So bite block should be there. Suction, especially Yango suction, should be kept ready. And we should explain the procedure to the patient. So in different ways we can correct this. So either the patient can be in sitting position with the head resting onto the wall, or patient can be in supine position. So it is better to keep the patient in a sitting position. Otherwise, if the patient is supine position, he might aspirate. So suppose this patient is in sitting position, how will we correct that? So we will have to wear the gloves. Then we will have to take a good set of gauze, and we will have to insert this one into the patient's mouth. Okay, so we will be keeping the gauze like this, and we will be inserting into the patient's lower tooth of or superior aspect of the lower tooth like this. So both the thumbs should be inside the mouth and holding the lower part of the teeth on either sides, and the fingers should be below the mandible. And what we should do is, first we should try to displace the mandible inferiorly, and then we will have to relocate that by pushing it posteriorly. So down and then take it posteriorly. So this is one method. This is actually the sitting method. If it is some other patient, if we are not able to make the patient sit, we can do the supine method. For supine method also, it is the same only, but we will have to go to the head end of the patient. Here also the method is same only. The thumb should be go as in as possible to the lower tooth, and the finger should be going below the mandible. Then we should push this jaw inferiorly and then posteriorly, and we should correct this one. Okay, and if this then some other methods are there. This is that is a pivot method is there. Is pivot method. In that, what we will be doing is, instead of the thumb going inside, we can insert the fingers inside, and the thumb can be positioned at the chin level. So the fingers will go inside and the thumb will be positioned at the chin level. So the thumb should push the mandible superiorly, and the fingers will push the jaw inferiorly, and then once the jaw loosens from that, then we will push it posteriorly, and so that it will get relocated. That is a third method. Then we have some other crude methods also, like we can use some examining mirror or some tongue depressors and all, and we can make the patient gag. So we can make a gag, we can trigger a gag reflex for the patient that may relocate the dislocation. So these are the 4 methods how to relocate this anterior dislocation of the mandible. Okay. Then what will we advise this patient? So the advices are, if this is successfully relocated, we will have to advise the patient not to open the mouth too much while taking the food, and then if at all this patient want to yawn, ask the patient to keep the hand below the mandible and yawn. Otherwise the mouth shouldn't be open widely. Then ask the patient to take soft diet and give NSAIDs or analgesics for the patient. And if this recurs, ask them to visit the oromaxillary facial surgeon or the dentist. Okay, I forgot to mention another method, that is the syringe method. Syringe method, if this patient's mouth is open, if this patient's as the size of the mouth, we can select the syringe. So in this patient, this 5 cc syringe will be fitting into the mouth. We can ask this patient to roll the syringe anteriorly and posteriorly. So if that rolling happen, jaw dislocation can spontaneously relocate. Or ask the patient to ask the patient to roll it sidewise. So that also is another method to correct this one. Okay, so we told what all advices to be given after discharging this, at the time of discharge, and next is when to call the dental surgeon in this case. So if it is a simple anterior dislocation, the ER physician can correct it and give the advices and discharge the patient. So indications to call the dental surgeon is if 2 attempts of this attempt to relocate is failed, or if the patient is having associated trauma, or if we are suspecting a fracture, if the patient is having associated facial nerve injuries or low GCS or features of any contusion, brain contusion and all, we should involve the dental team, and also the neurosurgery department should be involved. Then if this patient is having more than 2 dislocations, then we will have to involve. So they will have to evaluate for the cause of this. What is the cause of the, is there any joint pathology causing this? So these are the indications when we should involve the dental surgeon. So this is all about the anterior dislocation of the mandible. Hope you understood this. Thank you. In the supine position technique, after suctioning all the secretion from the mouth with the gloved hand and gauze, insert the thumb, the mouth and other fingers below the mandible, give a caudal pressure and then relocate the mandible back posteriorly. In the traditional technique, we will be inserting both the thumbs in the mouth and the fingers should wrap around the mandible, and we will be giving a inferior and posterior pressure. In the wrist pivot technique, the fingers should be on the occlusive surface of the lower molars and the thumb should be at the mentum. And thumb should give an upward pressure and fingers should give a downward pressure to avoid mandibular fracture, and then we can relocate the mandible. In the syringe technique, take appropriate size of the syringe which can fit into the oral cavity and ask the patient to bite it and push it anteriorly and posteriorly.